Kong College of Cardiology, the Hong Kong Public Hospital Cardiology Association, Hong Kong Stent, the Macau Association of Cardiovascular Interventions, Singapore Cardiac Society, the PCI chapter, TCIP, proudly in collaboration with Biotronic. A quick disclaimer, this content is copyrighted by the APSC. The views and opinions expressed here belong solely to the faculty members and not necessarily representing those of the APSC. This webinar is currently made live streamed by Wonder, APSC Facebook and YouTube pages. CME points will be submitted for those who are connected throughout the full duration. You will then receive your certificate of attendance upon completing a survey sent by email. For participants calling in live, please click onto the Q&A box below to submit your questions, if any. I'm very happy to have two good friends as a lead Helm today. Respectively, from Spain, we have Dr. Merida CARDENAS from the University Hospital of Girona, as well as Dr. Sarah ZAMAN from the Westmead Hospital, University of Sydney, Australia. Now back to you both, Merida and Sarah, to introduce the rest. Sarah?
Yeah, thank you. So I'm really excited to be here tonight. We've got an all-female presenting team here from all over the world, many different countries, and we've got some fabulous panelists joining us as well. First up on the ranks is Associate Professor Sonia Burgess, who's hailing from Australia. She's an academic interventional cardiologist at Nepean Hospital and UNSW. She's got an interest in complex coronary intervention and has been very extensively published. We're also excited to be joined by Professor Yan Li. She is hailing from China, where she's the head of cardiology at Chengdu Hospital and the 4th Military Medical University. And she also has a very strong background in CHIP, CTOs, complex interventions, and has been extensively published. And lastly, of course, we all know Dr. Lam Ho, who is joining us, and I'm sure doesn't really need an introduction in this forum. So I'll move on to Merida.
Hi, good morning. I'm also very excited to be here and happy to present good friends of mine, Professor Jack Tan. He's the head of cardiologist, and he's also part of the board of the Asian Pacific Society. Dr. Leticia Fernandez, who is an interventional cardiologist who has an MD in structural interventions and works here in Spain. And Professor Eric Eckhout, we all know him by his excellent course of complications, among with other achievements of being professor of the Medical Medicine University and being part of Asia PCI and the editor of the book of intervention in PCR. We're happy to have these women also presentation, because we want also women to be in view and be held as someone that can do great things in the cath lab and solve many problems that are sometimes presented. Back to you, Sarah.
Thanks, Merida. So we're very privileged to have our first speaker here. I've seen her speak many times now. It's Dr. Mirvat ALASNAG, who's from Saudi Arabia, and she's actually the first female interventional cardiologist in the Gulf region. And so she's very well known, very extensively published, and has a lot of interest in complex coronary intervention. And she's going to present a case here for us today. Thank you, Mirvat.
Thank you, Sarah, and everybody for the kind invitation. And may I share my screen, please? So it's very exciting to be here to learn from everybody and perhaps engage with everyone. This is actually one of the more difficult cases, not only because of the PCI that we ended up doing, but I think the decision-making process and getting to the point where we decided to revascularize the patient and how to do so. So I don't have any relevant disclosures for this presentation. This was an 82-year-old gentleman. His cardiovascular risk factors were primarily hypertension. He had had class 3 angina on optimal medical therapy for approximately 6 months. And so very stable, but ongoing chest pain. He eventually presented to us with an acute coronary syndrome, namely a non-ST elevation myocardial infarction. Upon admission, he was hemodynamically stable. His echocardiogram showed a normal LV systolic function and no significant valvular heart disease. He only had mild renal dysfunction. His estimated GFR was approximately 60 mils per minute. And this was his diagnostic angiogram. So this was the right coronary angiogram. You could see a diffusely diseased right coronary artery that was non-dominant and was supplying collaterals to the left. So we already anticipated what we'd be seeing on the left system from the first shot over here. The left system, what you could see is a normal left main and a dominant circumflex. The LAD was occluded after the diagonal branch, but the diagonal branch itself had osteal disease just at the bifurcation, and there was a disease in the LAD itself immediately after the ostium of the diagonal branch. So it was very strange that his LV function was quite normal. And he did have only a non-ST elevation MI, however, his LAD was completely occluded. So we opted to pass a wire, and with just passing the wire, we established flow. So we probably caught him in the right window before he has a full-fledged myocardial infarction, and his EKG did not show an ST elevation myocardial infarction. So after passing the wire in the LAD, re-establishing flow, we did, and we've made a habit of this, that is particularly if it's during work hours, we get an opinion from the cardiac surgeon. That, you know, we're looking at a bifurcation disease in an 80-year-old man with preserved LV function. Our patients, and I have to tell you, our patients who are 80 years old are probably the equivalent of somebody who is a decade older in the West. They just age quickly. Chronologically, they're just more frail and more dependent on family members. Part of it is cultural. Part of it is part of the respect of elderly in our culture is that you respect them, you hold a chair to them, you walk them, you carry things for them. And I think that makes them more and more dependent and more feeble. So naturally, the surgeons weren't particularly thrilled with the distal targets and thought if we could proceed with PCI of a bifurcation lesion in an 80-year-old, we should go ahead and do it. So we made that attempt. But what ended up happening is we couldn't have anything cross. This was actually a non-crossable lesion. And if you look at this angiogram over here, I'm going to give you, so this is a balloon that's across, there's a wire in the LAD, and there's an over-the-wire balloon that's sitting across the lesion. But beyond that, we couldn't get anything else to cross. So this is actually it. You see the middle marker of the 1.2 balloon that we ended up parking over here. We figured we'd dilate and see if it would yield. It actually never yielded. And we couldn't get anything else bigger than a 1.2 to cross. So this was a non-crossable lesion, but we're talking about a bifurcation disease. Both LAD and diagonal needed treatment. So our option was obviously rotablator. I think shockwave and so on would have been difficult to cross. If we couldn't get a balloon that's more than a 1.2 to cross, it would be difficult to get a shockwave or a lithotripsy balloon to cross. And we ended up doing rotablator with a 1.5 and then escalated to a 1.75 burr in the LAD. Naturally, we can't wire the diagonal at this time and opted to start with the LAD. We subsequently shifted gears and put our rotawire in the diagonal branch and started to rotablate the diagonal itself. This was actually surprisingly more difficult than the LAD itself to cross, and it took several runs, and we actually went up again with the burr before we were able to cross the lesion. So afterwards, we ended up putting wires in both vessels. This is what it looked like after the rotablation. We opted to do some dilatation at this point to get better expansion. And so we dilated the LAD and the diagonal. What we were hoping for here is to keep it as simple as possible, bearing in mind the age of the patient and so on. Bearing in mind that after two vessel rotablation, the patient is getting tired and it is done on conscious sedation. But also we have to look at the anatomy and see if it's suitable for a two-stent strategy, and if so, which one. The angle was not very helpful or not very encouraging for a tap technique. Nevertheless, we tried LAO caudal views, which I'm sorry are not here, but you'll see them at the end. And it was relatively sensible to try it. But we figured we'd treat the distal segment of the diagonal first and then come back and focus on the bifurcation lesion itself. We ended up deploying the stent and post-dilating it, and then we deployed a stent in the LED itself, giving ourselves room for proximal optimization. After doing the post-dilatation, we recrossed into the diagonal branch, opened up the struts over there. I don't have an image of proximal optimization, but we actually do pot before we recross. It just helps the recrossing. And then we're trying to position the stent again. This is not the optimal view. Actually, what we found was the spider more optimal in the positioning. We ended up deploying the stent, doing our kissing inflation, positioning for proximal optimization and trying to stay clear of the neocarina, doing the proximal optimization. And then this was the final result in the LED and the diagonal. The patient fortunately did well, did not require a lot of, his renal function remained patent, and given his normal LV function, we felt we were okay being generous with the fluids and hydration for the procedure. This is the LAO caudal, and you can see the diagonal and LED bifurcation is fairly intact. So, when we go into these complex procedures, particularly ones that require debulking or atherectomy, it is wise to do intracoronary imaging, whether by IVUS or OCT. So IVUS actually demonstrated, and this had to be done after, some of the debulking, because if we couldn't cross with regular balloons, our intracoronary imaging catheters likely will not cross. So we ended up doing it in the interim between the stenting, and some of the segments that did not yield, this is one of them, where you can see heavy calcification on OCT. You see some cracks where you see here around 6 o'clock on this one that I'm marking over here. And then again, you see some dissections over here. And this is a little more images of them. The two square panels that I have in the bottom, these are not the same patient, but ideally, if we had used shockwave, this is what it kind of produces on intracoronary imaging when we do it. You see nice dissections that permit you to expand your stent afterwards, and that's what you look for. But in our patient, what you see in this big square over here these are the kind of cracks that you would get in the calcium, and that's what you're hoping for to achieve with atherectomies. There are several algorithms that have been published, and the most important is, looking at balloon crossability or not. So if the patient is a yes or a no. So this was a no, we didn't have a decent sized balloon to cross. So it wasn't crossable. Well, are you able to cross with a microcatheter? And that is the next challenge. So if the answer is no, perhaps consider direct wiring. If yes, then exchange immediately and do either rotational atherectomy or orbital atherectomy. We opted for rotational primarily because it was more circumferential and less limited to one side. What we've also learned to do is, even if you can put the nose of a small balloon over the wire balloon or a small microcatheter and at least negotiate the lesion with the nose of the catheter, then it's probably easier to pass the rotawire or the Viper wire rather than starting from the beginning and from the main catheter, the guide catheter in the left main. And then obviously afterwards consider balloon dilatation. Now, if you're unable to directly wire the vessel, laser atherectomy is an option for those of you who do have laser atherectomy, where it can be done as a step-by-step procedure. And you can do it over the wire that you already have crossed, 014 if you're able. So if you weren't able to cross with the wire, you use the step-by-step technique. But if you were able to cross with the wire, you can apply your laser atherectomy. And then, of course, you need to do intracoronary imaging. But, some colleagues, and I don't know if this has been validated yet, now with the multitude of options for atherectomy, be it cutting balloon, laser atherectomy, rotablation, CSI, and more recently the NUCID in the block, the lithotripsy, some of our European colleagues have come up with a scoring system where they do the intracoronary imaging up front and they determine a score system for the patient. They look at the arc of the calcium. If it's 180 to 270, that's 2 points. If it's over 270, that's 3 points. If the thickness is more than 0.5, that's another additional 1 point, and so on. And then they look at how they respond. And if 3 to 5 points, they consider lithotripsy. If less, they consider high pressure balloons, and so on. but it still pretty much focuses on whether the lesion is crossable or not. Very important that as we adopt intracoronary imaging, we get comfortable with the technique. So whether it is OCT or intravascular imaging. I know our lab has been focused on intravascular ultrasound a lot more. More recently, we're trying to learn the OCT and to get comfortable with it. I have to admit, I'm still not 100% comfortable interpreting all the images on OCT, but I think it's the learning curve. And once you get over it and you've seen enough, it's repetition. The more you do, the more you'll see and the more comfortable you are with the measurements, and it becomes a lot more fluid for your lab and the setup. So when you look at somebody with lithotripsy and you look at the calcium pre and post, these are the kind of dissection planes that you do want to see that will reassure you that your stent will subsequently expand. That's for the top panel. The B panel is using cutting balloons. Again, this was done by IVIS. And then looking at rotablators, and rotablator, if you look at over here, so that was pre and post. And post, what you see is the cracks that you can see and the linear dissections, small linear dissections that you are able to find. Of course, if you're dealing with an in-stent restenosis with calcification, you can perhaps use lithotripsy. Some of the other technologies are considered off-label use. But ultimately, if you're a lab that has orbital atherectomy, laser atherectomy, rotational atherectomy, you need to know how each of these works. I'm not going to bore you with these details, but there are several resources out there. But you have to also understand the advantages and disadvantages of each. So where you're looking at, preferential or differential calcium, when you're looking at deep calcium, and so on, to be able to make the difference. I think, more recently, as I said, the Disrupt series came out for lithotripsy and some comparative data with rotablator. Of course, this is an old trial, the rototaxis with the TACS stents at the time, and looking at acute luminal gain and showing that there is an appreciative acute luminal gain with the Disrupt trials for the lithotripsy. But other considerations to bear in mind are the availability and cost, the operator experience, I would say the coronary anatomy as well. So looking at the distal segment, I'm very reluctant in somebody with the last remaining vessel and a poor distal segment that's diffusely diseased or a poor LV function to do atherectomy such as rotablator and so on, because when they do have distal embolization, they can really spiral and their blood pressure drops abruptly. And so those, I try to finish them quickly. So if it's feasible and I can cross with something like a lithotripsy, that would be my choice. In a bifurcation lesion like this, it's ideal to be able to retain wires in both the branch and the main vessel. And so, again, lithotripsy would have been my ideal choice, possibly laser atherectomy, because you can retain the wire. On the other hand, you can always get a dissection with balloon dilatation, whether it is with lithotripsy or with cutting balloons and so on. And atherectomy devices such as the rotablator ensure that you don't get dissections within the bifurcation segment where you're planning to cross and recross and cross and recross during the procedure. So thank you very much. I think I'll leave it here and perhaps open it to discussion with the rest of the panel. So Sarah, over to you.
Great, thank you for such a wonderful presentation. Now, if anyone has any burning questions from the panel, please raise your hand. I don't think we have any in the QA at this stage. Otherwise, I might ask my first question, if that's okay. I was really interested to hear that you would call the surgeons down to the lab for an 82-year-old with a STEMI. Sure, I mean, CABG is always an option, but our surgeons are never that keen to take patients having a STEMI, let alone 82-year-olds. Can you comment, or does anyone else want to weigh in what their institutions are like?
So, yeah, we don't always do it, to be honest with you. I think it's just important to understand that it is an option, and more so during the work hours, that we need to hold our surgeons responsible as well, and they need to be invested in these procedures as well. But I think more importantly, most of the time, when I'm a little bit concerned, I involve the surgeons early so they're available for backup. Should anything go south, let's say I'm unable to cross, let's say the patient gets a dissection that I'm unable to control, or what have you, then at least they're aware that this kind of a patient is in the lab and this is the kind of procedure that's happening and there's somebody standby. And I think that's what happens. I've learned over the years that the communication with our surgeons keeps them engaged with simple cases, with complex cases, and you start to develop a work dynamic with them. They understand you and what your capabilities are, and you understand them and their boundaries as well, what they're willing to take and what they're not willing to take.
Absolutely. I mean, Prof. Yan, do you have any comments from your institution in regards to what you would do in that situation?
I have some comments. It's really a very challenging case, especially when cavity calcium lesion met ACS. It's quite difficult. So in this situation, when you start a rotablation, do you have many measures to prevent slow flow or no flow in such a situation? Yeah.
Thank you very much for mentioning that. Yes, so preemptively, particularly when we're doing atherectomies and particularly with patients who have last remaining vessel or poor distal bed, we pre-treat. And patients who, after I establish flow in a STEMI, for example, those I pre-treat. So yes, I would administer intracoronary adenosine, calcium blockers, nitroglycerin, you know, the whole spiel. And a lot of the times, if I do see a large thrombus burden, but this is different, you know, I'd make sure that our staff is ready with everything mixed and ready to go, even if I don't actually administer it, but it's available and on table. But yes, thank you very much. We do routinely do that, absolutely.
Yeah, for this patient, because it's very elderly person, and the RCA is non-dominant RCA. So for a very huge LAD and you rotate the LAD and the diagonal. So in this situation, I suggest maybe we implant pacemaker to prevent some quite bad situation. Maybe it's safer for this elderly person.
Great. We might move to Dr. Letitia. You had a comment?
Yes. Hi, everyone. Thank you for the invitation, Dr. Merida and Sarah. And I want to know if in this case, because the important thing is not to lose the wire, no, and what is the sequence for rotablation, the side branch and main branch, when you have two branch with a very diffuse disease, because you can lose one branch. So you have an order or a sequence for this issue? I will know because it's always the doubt, no? Start with the side branch or the main branch.
You know, some operators, but I have not done that, they use microcatheters as well to help secure the branch and then rotablate beyond. I have not actually done that, and sometimes it's a little bit difficult with narrow angles where the microcatheter doesn't actually permit you to secure it very well, simply where the ports are located on it. But I generally would focus on the main branch. I think to me, the main branch is the one you want to secure, you want to ensure first. And I think it would be ideal after ablating, which I didn't do, and we should do, and we should get into the habit of letting intracoronary imaging guide us, is after you've secured the main branch, I think ablated the main branch, you're probably going to feel better about yourself if you do imaging and see that, you know, there aren't any major issues, any major dissections and so on, where you're going to fear losing that wire if you're going to ablate into the side branch.
Yes, thank you. And after to predilatate the side branch, because the result is pretty good, after rotablation, the side branch and predilatation, did you think in the possibility of the provisional stent technique? Only treat the main branch with the proximal optimization and maybe kissing or side by side?
Yes, I think you're absolutely right. I think keeping it simple and provisional, particularly in an elderly or somebody who's high bleeding risk, is wise. I think we opted not to because there was significant recoil in the ostium of the diaphragm.
Okay, congratulations for the result.
We'll just move across to Sonia if you want to. You've got your hands raised.
Hi to everyone. Thank you. Beautiful case, Mirvat. Just really, really good. I thought the comments you made about decision making, about getting experienced with imaging and discussions are really important. I've worked in hospitals that have surgical backup and non-surgical backup. And whenever I have surgical backup, I think particularly as an early career interventionist and as someone who sometimes we all face criticism, I think it's really, really pragmatic to involve people like surgeons so they're engaged with the challenges beforehand. I think it's really smart. Sometimes interventional cardiology is a game of chess and you're playing not just this point, but your third and fourth move down the road where you've got an engaged team who know what's happening and have walked through that decision-making with you. So I think even though sometimes it is surprising to ask for something that you ultimately think will be turned down, I think it can be a really great strategy for keeping everyone safe.
That's great. And do we have any other comments from our panelists? If anyone has a question, raise your hand. Otherwise, I'd just like to ask Mirvat about the idea of complete revascularization in this patient. I mean, I know he's 82 and you said he's 10 years older than 82, but he had a lot of disease elsewhere. When would you look at revascularizing the other vessels?
So I think complete revascularization, the average age was much younger than this. So they were in the 60s. I don't know if this is something that I can extrapolate to my patient, but over time, I've learned to engage my patients. I do feel that the angina that he had for 6 months prior to the event was likely coming from the critical disease in the mid-LAD and diagonal. So I would continue optimizing medical therapy over a course of time and seeing if he stabilizes or not. I would give him the option of a second procedure if he wants. The only problem with the second procedure is it's really very distal vessel. So there's very little that I can actually do. There's not much we can do in the cath lab for diffuse distal disease. Perhaps in my part of the world, we do have drug-coated balloons and I would consider those. But even with drug-coated balloons, I've learned it the hard way that sometimes you don't get away with ballooning alone. Sometimes you will have a dissection and a flow limiting dissection, even though your intent was just to do drug-coated balloon and get out without stenting. But you always have to keep in the back of your mind that you may end up requiring a stent. And so I think weighing risk and benefit is a discussion that I would have with this patient. I did not choose to do revascularization in this patient later.
Absolutely. Yeah, I think really the point is revascularizing major epicardial vessels, certainly not side branches or small distal disease. I think we better move on. We better wrap up the discussion. Thank you for an amazing case, and I'll hand over to Merida.
Thank you, Sarah. So we're not going to present my friend Livia GHEORGHE, who's going to present the next case. She's one of the interventional cardiologists in the Hospital Puerto del Mar in Cadiz, and she's also has an Intracoronary Imaging Techniques fellowship, and she's also very interested in complex procedures, coronary procedures, and structural. So Livia, there you go.
Good morning or good afternoon, everyone, and thank you for this kind invitation to participate to this meeting. I was asked to present the Tavi case complication. So I'm going to my presentation. Okay, can you see my slides?
Yes.
Oh, that's good. So nowadays we barely have Tavi complications because of we know better the technique, and also the devices are better than the years before. And this is one of our most interesting cases of Tavi complication. It happened like 6 years ago. And I really like to call this case complication in the cath labs and solved in the cath lab. It's regarding an aortic rupture during Tavi. Okay, so our patient is an 88 old woman, and she had several risk factors. She has renal insufficiency. She had 2 surgery, a hip surgery and a spine surgery, and also she had the AV block with a pacemaker implantation and atrial fibrillation in 2006. We met her in 2016 when she had stable angina, and we implanted a stent in the LAD. However, the patient was still symptomatic, and an echo was done, which showed a severe aortic stenosis. At that moment of time, she was on clopidogrel, aspirin, and acenocumarol. We decided to do Tavi because of her age and also of her STS score. It was 4.5. And at that moment of time, we still did the procedure with general anesthesia, guided by TE, and was a Tavi procedure, transfemoral access with preclosure with ProStar. We wanted to predilate and implant a Lotus valve 25. So we start with the access. And we check before the femoral arteries. As you can see, they are quite good without any calcification, with mild tortuosity. And at the aorta, at the descending aorta, you can see here moderate tortuosity, and also at the level of the aortic branch. So we had the access, percutaneous access, and we predilate the valve. It was quite simple to predilate the valve, but when we want to advance the valve, we had the problem. The device was kinked and was almost impossible to advance across the aortic arch. And you can see our wire, a safari wire, went out of the ventricle. At that moment, the patient started with hypotension, and we perform an angio. And as you can see here, there is some contrast going out from the aorta. The patient started to be very hypotensive, and the medication was started also. At that moment, we had also the TE, and with the TE probe, we could see that our aorta was ruptured here, and we could see also the big hematoma in the thoracic space. At that moment, we didn't know. We thought what we can do, and that is our question: what's next? How to solve this complication? Open surgery. It could be an option, but we can lose a lot of time preparing the OR room, and the patient may die meanwhile. Conservative treatment, we can think, okay, we reached the limit, the patient is 80 years old, and this is a very important complication, and the patient may not survive her, or we can do percutaneous treatment. We had luck that the patient was relatively hemodynamic stable, and she went quite well with noradrenaline perfusion, blood transfusion, and saline infusion. And also, our team was composed by an interventional cardiologist and cardiac surgeons. Cardiac surgeon who had experience with the TEVR implantation. So meanwhile, we were waiting to prepare the TEVR device. We inflate the balloon that we had for the predilatation, and nucleus balloon at the level of the bleeding. And the nurses prepared the TEVR device, and the cardiac surgeons start to deploy the TEVR Valiant into the aortic arch below the subclavian left artery. This is the result after implanting the first device. We still had some contrast going out to the thoracic space, and here you can appreciate the big hematoma that was created by the blood. Also, you can appreciate in the fluoroscopy. At that moment, we decided to implant another TEVR. It was just to try to seal better the hole we produced there. And here you can see both TEVR at the aortic arch. And we try to respect the subclavian artery and not occlude it. The patient went well. went quite well. She had only a mild hemoptysis, and she was extubated at the 3rd day and discharged at 7th day. Here you can see the images of the CT scan with the two Valiant TAVRs. And here you can appreciate the big hematoma at the thoracic space. The patient went home with clopidogrel and fraxiparine since she had a recent stent implantation and fraxiparine due to her atrial fibrillation. This is the radiography. Here you can see how was after the procedure, and we follow up her also with the CT and X-ray, and at 3 months for follow-up, you may see that the hematoma disappeared. And now, what should we do? She is 80-year-old. We saved the patient from a very important complication, but the patient was still symptomatic with angina, and how we should treat the aortic stenosis. Now we have 2 TAVR into her aorta, and how we could treat that. Open surgery is not an option, was not before, and is not now an option. Conservative treatment is also not an option because this patient was quite vital, although she was 80-year-old, and we went back to the Tavi. Transfemoral, we didn't want to cross again to that arch where we had problem. Transcarotid and transaxillary access. At that moment in 2017, we didn't have experience with those access, so we decided to go to transapical access. So at 1 year later, we decided to implant a Tavi through our transapical access. We predilate the valve again, and we implant a sapien valve. In conclusion, it's very important to think that during Tavi, complication may occur. Nowadays, they are fewer than maybe 6 years before. We have to pay attention to all the details. We have to pay attention to the wire, and we have to stop when we feel that we have a block there, and do not push too much. We have to be prepared to face the complications, and it's very important to work in a team to solve these complications. I mean, it doesn't have to be a cardiac surgeon on the table at the table, but maybe a vascular surgeon or radiologist has to be aware how to solve these complications. Thank you.
Thank you, Livia. It was a great case. I would like to know if anyone from the attendees will have any questions to share with us. Meanwhile, I would like to first ask you if you consider to use a different device would have solved or prevent this complication in the first place, instead of Lotus, a different kind of valve.
At that moment, we use a Lotus valve, and as you know, it's a very bulky valve. And it was just at the beginning of our experience with Lotus valve. And I'm not sure if we could avoid this complication using the other valve. But the most important thing is just to be focused on your wire. And if you feel that it's not going well, just check with the X-ray. The aortic arch was tortuous, but not so tortuous as other cases we did, and was not calcified. I think it's very important to pay attention to the details during the procedure.
Okay, we have a question now. In the meanwhile, while I can review this question, is there any other comment from the panelists?
Maybe I have. Okay, you're first.
No, you're first. Sorry.
Sorry,
please.
Thank you. No, but I think that nowadays with the flex nav, of the portico valve is a good option in this case, for the angulation of the aortic and the curves, in the way, to cross to arrive to the valve. So I think that at this time, because you didn't have this valve, but it's a good option, I think, nowadays.
Of course, but probably we didn't think that tortuosity was too important. So I'm not sure if the tortuosity was the problem, or maybe we didn't pay attention during the procedure.
No, or maybe the tension, no? I think that the tension on the material, no? Maybe no, you force, you push, you have no sense to push, no, strong, but no, the result is no the tension of the material, I think.
We could use maybe a stiffer wire like a Linderquist wire to advance the valve also.
Yeah.
Okay, we have a question from our attendees. Has anyone had experience doing Tavi through a keyboard? Personally, I don't. I don't know if any of our panelists had.
We don't have experience, but we had experience to doing combined procedure. When we had the aneurysm at the aorta abdominal, you implanting Tavi and then put a TAVR device also.
I have some questions. It's really very challenging cases. Very elderly person. I want to ask, what do you think the main reason you caused the dissection? It is due to tortoise or calcified? I noticed the calcification is not so heavy along the aorta. It is due to the tortoise?
No, I think it's the fact that we push at that angle, and the valve was quite bulky at that moment, and we didn't control very well the wire, because you saw that the wire went out also of the ventricle during the kinking.
Okay. Maybe do you think if you use a snare, it will be helpful to prevent it?
It could be used, of course. But at that moment of time, we thought that it was a quite easy case. So when we saw that we couldn't advance the valve, we checked and we saw that was kinked. And that moment also the patient started with hypotension, and we decided to pull out the valve and solve the complication problem.
Yeah. My second question is, I noticed you first choose the Lotus as your choice for the Tavi. So my question is, after you finish the TAVR, the second time you will still choose Lotus as your choice?
We didn't have experience with Lotus in transapical access, so we went for Edwards, for Sapien.
So only Lotus is available in your country?
No, at that moment of time we had 5 valves using. We could use 5 valves, but since the valve was very calcified, we decided to use a Lotus valves. As you know, that it was very good for calcification, and this is why we decided to use Lotus. And we changed for Sapien because also Sapien has a very good radial force, and it's very useful in those cases with very calcified annulus.
Yeah. Okay. Professor Eckhout, do you have a question?
Yeah, sorry. I wanted to make a very small comment. If it's indeed an unusual complication, and mostly these patients will pass away, so I think that we have to pay a tribute to the way you handle this, because in most countries and most labs, this patient would be lost because there is not the infrastructure and the speed of action of vascular surgeons or whoever will be there to help you. So yeah. I think that's what I wanted to say.
Yeah, that's very important. I mean, each country has their own rules and who has to do TAVI. And in many countries, there are only interventional cardiologists in the room. Nowadays, the TAVI is going very smooth. But I think complicated cases we should share with cardiac surgeon or vascular surgeon those patients and do it together.
Yeah. Yes, I think it's like in this case before, we have complex cases. We also need to have the backup of someone, and get them involved in the procedure, because you never know when you're going to have a complication. And it's good to know that you have that backup and that they are aware of these complex cases that we're doing now.
Yeah,
So if there's...
Yeah, well, we don't have the backup there. These things happens, we rarely also have some complications, but then we have to call in the vascular surgeon, and they may be in the OR, so it's not always that easy. So there is a little bit of luck involved too, for sure.
Indeed, yeah, this patient had luck.
Yeah.
And that happened 6 years ago, and I want to say that the patient is still alive now with a 94-year-old, is still doing well.
One last question, Livia. After this experience, do you call the vascular surgeons to be like on the stand beside you in case of any other complication like this arrive, or you just have different way of handled?
This case is from the Netherlands, and there was a very good relationship between cardiac surgeons and interventional cardiologists. And I said the cardiac surgeons, they were very used to implant TAVR, and that was a magnific. Here in Spain, we do Tavi alone, with only interventional cardiologists. But yes, we have the cardiac surgeon and also vascular surgeon aware that we have more complicated cases, and just to keep an eye that if it's something happen, maybe they can come and help us.
Right, that was, oh, sorry to interrupt.
No, go ahead. So if we want to go with you, Sarah, for the next case.
Yeah, thanks, Merida. Livia, that was amazing. Congratulations. Such a fantastic case. So we're going to move on to our next speaker. We've got Dr. Carmen HO joining us. She's from Hong Kong, China, where she's a resident specialist. And she's going to be presenting a case. I understand she has a lot of experience in complex PCI, as well as an interest in acute and chronic heart failure, and has been an operator for several Impella cases. I'll hand over to you, Carmen.
Thank you very much for the invitation, and I'm so honored to be here to discuss cases with all the worldwide experts here. So let me share my screen first. So I'm coming from Hong Kong. So my topic today is to make a failing heart strong again. So my case is a 62-year-old gentleman who is a chronic smoker and drinker. He had no diabetes, but had been developed for a few years already. And he presented to us last year for heart failure symptoms, and he had no angina symptoms at all. And we did an echocardiogram for him, which shows that there is a severely impaired LV systolic function down to 30%, and with a global hypokinesia. So with patients with risk factor of diabetes, impaired LVEF, we also did a coronary angiogram for this patient. And this is what the left side coronary angio show. You can see that there is multiple critical stenosis over the proximal to distal circumflex arteries, with some retrograde for the to the right side. The LID is not much better. Proximal part is still looking okay, but there are multiple critical stenosis along the mid to distal LAD. Another view showing the LAD with multiple diagonal from the critical LAD lesions, retrograde to the RCA. So we expect the RCA will not be good as well. So the RCA also show critical stenosis at the proximal RCA. Actually, it's like a functional CTO, and you can see the competitive flow at the end of the RCA. So it's a triple vessel disease with multiple critical stenosis as a functional CTO over the RCA. So my next question is, what's the revitalization plan? So indeed, for this patient who is relatively young and healthy with diabetes, impaired LVEF, and also triple vessel disease, CABG will be the first on the list, but the patient actually declined an open heart surgery. So the next step is, can I perform PCI safely in this patient? So the patient has heart failure, have diabetes, multi-vessel disease, complex lesion, with a severely impaired LVEF, they all contributed to a very high-risk PCI for this patient. But indeed, if the patient declined open heart surgery and PCI is, I think, is challenging, but it's actually visible. And with multiple high-risk factors for this PCI, I decided for Impella as a PCI for this patient. And I will show you a live recorded video, which is developed by Dr. Lam in our center. And it's a very good video showing you how we do the procedure. We have an angiogram. Can you see the video? Yes. And we have the hemodynamic show here. We have condensed the 4 hours PCI to 8 minutes. I skip a bit in the middle to make it a little bit faster. So we have a right radial access and a right femoral access. We did under ultrasound guidance. We did an Impella, and we designed to the PCI via the Impella sheath. We use 7/6 French terminal sheath to insert in the Impella. We decided to tackle the RCA first because the left side has multiple critical stenosis, but it's supplying the RCA from retrograde. And we decided to do the RCA first. Very luckily, I can wire the RCA with a workhorse wire under a careful with a microcatheter support. The wiring is not particularly difficult, especially I think it's mainly some fibrous plug, but not very calcified. So I can easily reach the end and wire the whole RCA. And after wiring, we pre-dilated it with a small balloon. And this is what the IFS show. Distal segment okay, proximal to mid-RCA, diffuse disease with heavy plug load. After further pre-dilatation, we put in a stent from the proximal to the mid-RCA. We post-dilated it, and this is the IFS showing the proximal part of the RCA. It's well expanded, the stent was well expanded, and we just landed at the proximal RCA. Angiograms show very good result. And after tackling the RCA, we go for the LAD and the circumflex. LAD multiple critical stenosis are over the mid to distal part. Wire it very carefully to avoid any dissection. I skip it a bit. And again, I can wire it with a workhorse wire. We pre-dilated it with a small balloon again. And I wire the diagonal for protection. And we did IFS to decide our landing and further pre-dilatation. And we put in the stent to the distal part. Actually, the distal LAD was very severely diffusely diseased with a core of a very small caliber. And we only can find a normal segment at the distal LAD that we can put a stent in. So we did not decide not to intervene the distal LAD part. We put in a stent, and then we did an IFS to see whether we need to go to the left main because the proximal part looked quite normal in the angio. The IFS is quite long, so I skip it a bit to the proximal part. So now we are in the proximal LAD. Again, it's not actually very good. The whole LAD is severely diseased, as you can see here. And the ostial LAD is also diseased with a heavy plug load. The left main is also diseased, although a minor degree. So we decided for PCI up to the left main bifurcation. We wired circumflex. Again, circumflex is severely diseased from proximal to distal. And after pre-dilatation, we put in stent. We need to like a metal jacket all the way from distal to the proximal. So this is how we do the bifurcation. We usually we like the mini crush approach a lot in our center. We aim for minimal protrusion to the left main. And after putting stenting, we ensure that we are just minimal protruded, putting a stent. And I think we all have a different strategy for doing a bifurcation. We usually do some post-dilatation of the side branch stent before we crush the stent. Because by doing this, I think even without first kissing, like in the DK crush approach, we can easily wire the side branch. And this is what the IFS show before we crush it, okay? So it shows the stent was quite optimally dilated. And there's some under expansion that we decided to pulsate again later on. And this is the proximal part. The stent was well expanded, and there's only very minimal protrusion to the left main. But ostium is well expanded. So we did a pulsation again with a NC balloon. And then and a pre-out dilated ostium again. And afterwards, we just proceed to our usual bifurcation approach by crushing the side branch stent. Then you remove the wire, and then you put in a left main stent. We really like to see the LA, the left main ostium by using a LAO cranial, which you can see the ostium clearly. And this is the iris from the left, from the LAD. Let's give it a bit. It's a little bit under expansion, just a little bit protrusion to the left main. We did a port, which I've not shown here. But you can see that actually by doing a pulsation before crushing the stent, the rewiring of the circumflex is actually quite easy. A workhorse wire can easily rewiring the circumflex. And a small balloon can be very easily passed through this ostium. And then we do the kissing, like the usual approach. And after do the kissing, we do the port. And now we are seeing the final angiogram. LAD, we decided to leave the distal LAD because it's a disability disease, small caliber. We don't want to do all the way to the distal LAD segment. Circumflex is beautiful. Left main bifurcation is very good. And so we have revascularized all three arteries with very nicely. And afterwards, the patient hemodynamics is good, and that is actually an elective case, and remove the Impella. And so usually we do the mini crush or nano crush. This depends on how much you protrude the side branch stent. And we find that post-dilatation of a side branch ostium is quite useful in rewiring the ostium, the side branch. Even without a first kissing, you can do it quite nicely. So our patients did very well. Hearing in a functional class 1, no angina symptoms. It goes hiking daily, even in the pandemic. And now you can see that actually his heart is moving very well, like a normal heart without any regional wall abnormality. So I go to my discussion point. When I think about this case retrospectively, I always have this in mind. Do I think we can do this case without mechanically surgery support? Indeed, the patient was doing well with Impella, and the PCI was quite smooth. So I always think whether we should do a PCI with Impella, because Impella have quite a high cost. The patient has to pay for it. Actually, the patient need MCS. And indeed, MCS is not without risk. We know it's a large wall catheter. It can cause a lot of vascular complication. We just have a case on Impella who had a femoral artery tear that required vascular surgery to intervene. And cause in hemolysis, we can cause a lot of complications. But indeed, with Impella, by having an adequate perfusion, you can complete revascularization patients. You can do more aggressive therapies, like you can do a very complex bifurcation stenting. You can do a lot of rotablation that without worry about hemodynamic compromise. But indeed, do every high-risk PCI need mechanical circulatory support? There's a paper published in Circulation last year looking at the feasibility and safety of high-risk PCI without MCS. And their definitions of high-risk PCI include these factors like unprotected left main, multivessel disease, severe ASMR, impaired OVEF, last patent vessel. Those patients are chronic ischemic heart cases, not ACS or cardiogenic shock cases, and they find that actually without MCS, they're actually feasible and have a very high successful rate, and bailout of use of MCS is less than 1%. So it's actually feasible to do high-risk PCI without MCS. So my question is, For stable ischemic heart disease, unlike cardiogenic shock or AMI, we have a lot of algorithm with a lot of risk score to tell you whether MCS is needed. But for stable ischemic heart disease, who will benefit most from MCS? These are just my humble opinion that I think for patients with very severe LV dysfunction, they do confer a very poor contractile reserve. By doing PCI, sometimes with the ischemia, they cannot tolerate and they will have a hemodynamic compromise. And especially if the patient is in a decompensated state, they have a high LVEDP, which converts to a poor prognosis usually. So by treating patient medically, medical therapy optimally, you also confer a very lower risk. And also if the patient, along with a poor LVEF, they also have complex coronary features like triple vessel, left bifurcation, large ring vessel, SVG graft, PCI, or severe calcification you need a lot of atherectomy. Then I think this patient may benefit from MCS too. So that's the end of my presentation. Please also share me your thought about what kind of patients do you think will benefit from MCS for those stable ischemic heart patients? What are the risk factors of high-risk PCI that you think that patient will need MCS? So thank you very much.
Great, fantastic presentation, Carmen. A really interesting case and really good discussion of all the different things that you need to consider with MCS. Although I should add another one, which is, does your institution have MCS? And I'm sure across different countries and different institutions, there's less access to it. And I'm sure we would treat this patient differently depending on what was available. Now, just reminding the audience, if you have any pressing questions, please put them in the Q&A. I might ask Prof. Yan first, and then perhaps Prof. Eric, what about in your institution? Would you have used MCS for this patient? Would you have referred to bypass surgery perhaps, or convinced the patient to go for CABG? Prof. Yan first. No, you're still muted. We'll go to Professor Eric. How about in Switzerland? What would
Eric
you have done?
is fine. We have Impella, and I must say that I was always an advocate, and sometimes we can do quickly, because you also have to counterbalance the risk of these assist devices. They don't come without any complication, despite the cost, of course. But I must say that these chip cases, we have to reflect upon them and to plan them carefully. And I would say that there are several factors we take into account: LV function, comorbidities, frailty, things that are quite difficult to explain. But in this patient, probably yes. Probably we would have used Impella, yeah. Also, on the other side, Impella is quite easy to use, and the device is improved, even the more recent version. So I would say yes, probably in this case. Nothing else to add on the technicity of the intervention, the complexity and the completeness of the revascularization. Nothing to add. And the point is also, if this patient is a chronic smoker and drinker, so does the LV function completely recover in the patient?
Yes.
Yeah, okay.
It's
So there
recover,
was not a really toxic component, so it was really ischemic then.
Yeah, ischemic cardiomyopathy, yeah.
And potentially a lot of hibernating myocardium there that then recovered so wonderfully. Sonia, can we move on?
Yeah, I guess I didn't really answer your question, but to be short, yes. And we're still trying to figure out the exact role of Impella, but it's increasingly used, at least in Europe, I think.
Thanks, Eric. And Sonia, you had a question?
Dr. Ho, I thought that was a beautiful case and really satisfying as an interventional cardiologist. I think we need to be as good at convincing our patients to consider CABG as we can be, but sometimes we can't. My question was actually about contrast sparing. When we do multi-vessel like that, we have to do everything we can to spare contrast. Can you run us through the things you do in your lab to be as careful with contrast as possible?
Yes, because when the Impella is on, then you aim for complete revascularization, and like all the study, like PROTECT2, like the Impella study, they use a lot of contrast, at least 200 mil for each cases. So actually in our patients, we use 300 mil of contrast. I think by using more intravascular imaging, you can actually aim for a lower contrast, low interpretation. You can mark all the landing by your IFS, and then you can do it with much contrast. You don't need to really inject a lot of contrast to see the angio. So I think if in this kind of cases, I will use more imaging, try to minimize the contrast volume.
Thanks, Carmen. Obviously, you did use a lot of IVUS, which I'm sure helped limit your contrast dose. Mirvat, you had a question?
I just had a very brief question, brief comment actually. Carmen, fantastic presentation and case. I think the dilemma of mechanical circulatory support always comes up. And the main reason is we don't have a lot of evidence that's been generated. The way I look at it is it comes at a cost to the patient, vascular complications, bleeding, etc. The only caveat is that, yes, less than 1% are going to need mechanical support when it comes to complex disease, high syntax score, high Euro score, etc. But sometimes you can't tell if your patient is going to be that 1%. And so preemptively, you keep your device either on standby with a sheath in, and then you just put the device in, or you actually upfront put the device in, because that 1%, if they crump on you, they can crump very, very quickly. And I always tell my patients when I consent them that the evidence isn't there, but it reminds me of like taking a long drive. Nobody in their right mind is going to travel from one city, 100 kilometers or more without having a spare tire in the back. Chances are you're never going to actually need it, but you have to have it. It has to be there. And sometimes I equate it to that.
The problem is that Impella is rare, is really not really available. It's extremely expensive. And I agree with you. People think that Impella is just it's easy. You just put on the autopilot and you are free for 3 hours. And I think that there are left mains of occluded tracts that you can do on condition that the LV is not bad. If you do a quick job and you anticipate, it's an easy thing to do. But don't forget there is more than that. I think that Impella can also protect to some extent the kidney function because you improve renal perfusion. So there's more than that, you see, in the whole scenario. Sorry to interrupt again.
Letitia, you had a comment?
Yes, I want to say that I think that the only opportunity to achieve the complete revascularization in this kind of patient in one procedure is the use of this support, because maintain the tension. We saw the tension of the patient during the procedure is more than 7, the media. So I think that's the only opportunity to complete revascularization. And in relation with the acute kidney injury, I think that you use more contrast, but the hemodynamic support, we saw in the PROTECT 2, the injury of the kidney is less than the balloon. So I think that we have to think in this kind of support and use image. I agree, completely agree, to decrease the contrast. But I think that the result of the injury in the kidney is less than with other support at the balloon.
And we might just have one last discussion point. Helm, this is your case, I understand.
Okay. Yeah, thank you. I think Carmen, you did a great job, and the whole case was did by Carmen. And I just want to make a very short comment about Impella. For use of Impella in Asian, in our experience, we found that hemolysis is quite common, probably due to the heart in Asian is relatively small. So when you use it, try the best to wean the Impella after procedure. Don't keep it out. If you keep your Impella out, then try to wean down the Impella and maybe go out with P4. We found that if we go more than P6, more than 1 day, always hemolysis and quite severe hemolysis. That's our sharing. Okay.
Fantastic. Well, in the interest of time, I think we better move on to the next case. Great case, great discussion, and I'll hand over to Merida.
All right. So we're now with this good girl, Nicola Ryan. I'm sorry to call you girl, but you're so young for me. That gratefully she accepted our invitation, and she's a consultant interventionist cardiologist at the Aberdeen Royal Infirmary at the University of Aberdeen. So here's to you, Nicole.
Well, sorry, I don't think anybody could hear me there. I'll just try sharing again. So thank you very much for the invitation to present my case today. I'm going to speak about left main stem bifurcation disease in a patient who's high bleeding risk. So this is an 88-year-old gentleman, and he lives in the north of Scotland. And in June of 2021, he presented with a posterior STEMI, and he lives probably about 250 kilometers from our centre. So he was thrombolized with a good resolution. And on arrival, he was pain-free, and a diagnostic angiogram was planned. So he has a background of an aortic abdominal aneurysm treated with a fenestrated EVAR in July of 2017. He has chronic kidney disease with an EGFR of 29 at his baseline, COPD, and he had a non-STEMI in April in 2021, which was medically managed in his local hospital. He mobilizes with a stick. He lives alone and has a carer daily to assist him with washing and dressing. And he had some mild cognitive impairment with a mini mental state exam of 23 out of 30. So post thrombolysis, we can see that he has a relatively good resolution of his posterior infarct with some anterolateral ST depression. His echocardiogram showed a low normal LV function with akinesis of his basal inferior wall and hypokinesis of his mid anterolateral wall, and no significant valvular lesions. Importantly, he had a community do not attempt resuscitation order in situ, and that had obviously been put in place by his GP. So he attended for a diagnostic angiogram. I'll just let play here for a couple of seconds. So we can see he's got a calcified left main stem. He's got a severe proximal circumflex disease followed by an aneurysmal segment, and that was most likely the culprit for this posterior infarct. He's got ostial LAD disease and diffuse disease all the way along the LAD, and he's got a CTO of his mid-right coronary artery. And again, that is possibly in keeping with the infarct back in April time. And we can see here he's got an EVAR in situ. So one of my colleagues carried out this diagnostic angiogram, and very sensibly, the patient was pain-free at the time. They chose to stop. They did put in a balloon pump, and that's the one issue in the case that I can't quite explain. I think perhaps it was just a slightly older operator who was used to putting in a balloon pump for people with left main disease. So we stopped to discuss them at our heart team. From a sort of a laboratory point of view, he has an anemia with a hemoglobin of 102 grams per litre. He obviously had renal impairment, which had worsened after his infarct and his diagnostic angiogram with an EGFR of 23. His peak troponin wasn't actually that high at 4,000. Unfortunately, on the ward, he suffered a GI bleed and he was commenced on an IV PPI infusion and was transfused. The gastroenterologists were consulted, but they weren't too keen to offer him endoscopy given the recent infarct. And on the ward, he had no further episodes of GI bleeding and his hemoglobin remained stable. However, he did then present with recurrent episodes of typical ischemic type of chest pain, and he was commenced on an IV GTN infusion. So at our heart team discussion, it's obviously a high bleeding risk patient. He's elderly, he's got renal impairment, he has proved himself with a GI bleed during his hospitalization. With regard to a potential PCI strategy, the initial imaging is unclear of the osteal circ, so we can't determine based on the diagnostic angiograms whether it's an upfront 1 or 2 stent strategy. He has a Euroscore 2 of 43.74%, and our cardiothoracic surgeons felt that his operative risk was prohibited. He was discussed, and we accepted that a higher risk left main stem LAD circumflex intervention was certainly technically feasible. Given the fact that on his echo, his inferior wall was akinetic, the plan was not to attempt CTO of his right coronary artery. And we planned to do a minimal contrast IVUS guided procedure given his renal impairment. Obviously, the inevitable discussion with regard to his DNA CPR status came up, and we had a conversation with himself. He didn't actually have any family. His neighbours were his next of kin, and he was understanding of procedural related complications and agreeable to obviously shocks and brief resuscitation if it was felt that the situation was retrievable. So we initially engaged with a radial 7 French EBU 375, and just immediately on engaging of the catheter, there was pressure dampening. So wired briefly into the OM branch to allow a diagnostic angiogram. And I think we can quite nicely see that there is involvement of the osteal circ, the distal left main, and the LAD. So it was a Medina 111 bifurcation. Initially attempted to pass an IVUS down both the LAD and the circumflex, but obviously, perhaps unsurprisingly, the IVUS wouldn't advance. So I did a gentle sort of predilation in both branches with a 2.5 by 12 millimeter balloon, and IVUS down both branches. Now, unfortunately, the IVUS is extremely corrupted and I can't get it to play. However, he had a distal landing zone in both his LAD and his circumflex of 3.5 millimeters, and his left main stem was 5 millimeters in diameter. So planned an upfront DK culotte strategy. So the IVUS obviously also confirmed that there was no calcium arc of greater than 90 degrees. So pre-dilated into the left main stem LAD and the left main stem circ with 3.5 millimeter balloons. And the reason I took a sort of a 1-to-1 pre-dilatation was obviously to ensure that the balloons came up nicely and we had a good preparation. All of these images were based on that initial diagnostic shot, the initial shot from the procedure and the diagnostic images from the initial angiogram to minimize our contrast use. Initial stent was into the circumflex because it is the slightly more acute angle with a 3.5 by 48 millimeter everolimus stent, and then post-dilated, potted and recrossed into the LAD. We did the first kissing balloon with 2 3.5 millimeter balloons. And then went on to stent from the LAD back to the left main stem with another 3.5 by 48 millimeter everolimus stent. And again, post-dilated, potted and recrossed into the circ with a further kissing balloon and a final pot. So this was the final angiographic result. We got a nice result in the left main stem LAD, nice result in the circ. IVUS did show that there was some obviously malapposition in this aneurysmal segment here in the circ, but I don't think you're ever going to oppose a stent well against that segment. And we can appreciate here, he still has diffuse distal disease in his LAD that intentionally didn't treat. And again, in his circumflex, he's got disease here, sort of more distally in the mid and distal segment. So overall, we used 60 mils of contrast and planned to medically manage the rest of his disease. So post-PCI, he was transferred to the coronary care unit for observation. He remained pain-free and his balloon pump was removed with fluoroscopic guidance. He was transferred back to his local hospital for rehabilitation. His post-PCI labs, his renal function remained stable. His initial eGFR picked up slightly, but that's just from the fluids during the procedure. He was discharged on aspirin, clopidogrel, his beta blocker, an ACE, and a statin. And his post-PCI ECG was unremarkable. And at 6-month follow-up, he's returned to living alone with his once-a-day care. He gets out for walks every day and he doesn't suffer from any angina. So some key learning points from this case. We're increasingly seeing patients with complex coronary anatomy that are deemed ineligible for surgery. And we really do have limited guidance with regard to the optimal management of this population. Obviously, this 88-year-old gentleman with his EVAR, with his renal impairment, with his degree of cognitive impairment, is not somebody who's been enrolled in any of the complete revascularization trials. We have the renal impairment, and we use the diagnostic angiogram images as well as the IVUS to minimize the contrast use and manage to complete a sort of a complex left main bifurcation case with 60 mils of contrast. He's a high bleeding risk patient, and obviously we want to achieve optimal PCI in all our patients, but it's particularly important in our high bleeding risk patients to ensure that our stents are well expanded, well opposed, so that if we do have to interrupt DAPT prematurely, that we're confident that our stents have been well implanted and the risk of a stent thrombosis is minimized. Given that he had a GI bleed, habitually we would prescribe a more potent P2Y12 inhibitor for our STEMI patients, but given his GI bleed, we maintained him on clopidogrel. As I mentioned, our bifurcation PCI requires a stepwise approach with meticulous attention to detail at each step. And given that this gentleman's renal impairment, his relatively limited functional status premorbidly, we decided to initially revascularize the left main stem LAD and circ alone rather than complete revascularization. And I think this is something that we do need to take into consideration when we're treating our older and multimorbid patients. So thank you.
Thank you, Nicole. It was a great case. I like it very much. I like the way you were doing it so meticulously and so well. Think about all the details, and especially the last part that we need to be clear about where our goals are. And our goal was definitely to have it without angina, but not to put so many stents in a patient in which we will not win anything. So we're open to any comments for our panelists and the rest of our presenters, if there's any. Okay, Letty, please go ahead.
Congratulations for the case and the result, and I think that incomplete revascularization is a good option sometimes. And I will to not to have the question, no, but in this case that you have a high risk of bleeding and high risk of ischemic events, no, what is the time, the perfect time to maintain the DAPT? How many months, or in this case, no, how many months the patient continue the DAPT? So we had made a plan for this gentleman that he'd continue his DAPT for 1 year post his STEMI, with the option to discontinue his clopidogrel early if he was bleeding. Now, his GP has been monitoring his hemoglobin, and obviously we've only been following him for 6 months, but he's not had any GI bleed, so he is still on his DAPT. I think it's something that you have to individualize. I think, you know, ideally we'd make a plan for a year with an option to discontinue early if there are bleeding or episodes of bleeding. Okay, thank you.
Thank you. Jack, you have any comment?
Yeah, it was a pretty similar comment. I congratulate Nicola. I really like the way it was presented. So many issues. I think this guy, the main discussion I would think would be balancing the ischemic and bleeding risk. I think he definitely fulfills all the major arc bleeding risk criteria. So I am a bit wary about some of the points that to sustain the DAPT up to 12 months, in spite of the fact that he was a high-risk ACS, because he has very manifested bleeding, he is 88 years old, and he has impaired renal function. So I would, actually, the way you did the intervention, that was beautifully done with a DK culotte, I would be quite comfortable to truncate down 3 months. And your comment about be ready to drop the clopidogrel, again, I'm not too sure the data out there. I think I would actually prefer to drop the aspirin, but consider maybe even a ticagrelor monotherapy approach like 12-LICA. But again, in the elderly subgroup, maybe single antiplatelet, you really chose a stent that has some data for shortened depth. But I would be more aggressive in shortening the depth duration in spite of the high ischemic risk for this patient. Thanks. Back to you, Miranda.
Thank you. Lam, do you have a comment, please?
Yeah, thank you. I think that's an excellent presentation. Dr. Nicola, I noticed you just used 60 mil contrast. You finished this complex bifurcation, so you must be an expert in bifurcation. So could you tell us the reasoning why DK culotte is particularly preferred in this case? Why not DK cross, why not cross, but DK culotte?
So I think some of it is obviously training and experience. When I was training, the preferred strategy in our center was a DK culotte before it was called a DK culotte. So it's what I'm very comfortable with. I think from a technical point of view, both branches are of equal size. You know, you're going to get a good distal landing zone, 3.5 millimeters in the circ, 3.5 millimeters in the LAD. So I think, like a lot of things, it's what your center has a lot of experience in, what your center has a lot of expertise in. And I think every bifurcation technique, you have to approach it step by step. There's no point in skipping out a step. And I know in Asia, there's a lot of experience with DK crush, and operators are very proficient on it. In our center, we do a lot of DK culotte, and we get good results with it.
Thank you. Livia, please go ahead.
Oh, it was a very educative case, Dr. Nicola. I really like it. You take care of all the details of this patient, very well managed. I wanted to ask you, for how long did you have the balloon pump into the patient, and if it really helped during the procedure? And the last question is, if you have some tips and tricks for patients who have ever and you implant the balloon pump.
Yes, so I didn't put the balloon pump in. I did his PCI, but my colleague put the balloon pump in. So he was about 5 days on the ward from the time he had his initial presentation diagnostic angiogram to the time of the PCI. We took it out. He had his PCI on the Friday morning, and we took the balloon pump out on Friday evening. We just had left it in to allow his heparin, his ACP, to drop. So that was why we didn't take it out at the end of the case. Did it help? I'm not really sure it did, but it was kind of one of those things that was in, so we didn't take it out pre-procedure. We had discussed whether we should use any other form of mechanical support. We have Impella, but we work in the NHS, so obviously it's restrictions for finances and things like that. And I wasn't particularly sure it was going to be hugely beneficial in this man. And sorry, with regard to putting it in with the EVAR, I'm not sure, to be honest. I think it's screening and ultrasound guided access for your punctures.
Thank you.
Eric, you have any comment?
Yes, I think we all need to congratulate you on this case. I think this was nice. Also, the tortuosity of these arteries makes it more complex to handle your way through, and you can very easily finally end up dissecting the distal LAD or circ while not watching the distal vessels. So congratulations. I also think there is an issue, at least in Europe, with IVUS, because there is a trend to consider OCT as a holy grail, and people are now better trained in OCT than IVUS. So there is really a need for better training in IVUS interpretation and use. I'm speaking about Europa, and I think it's really a point of concern. And I think your case highlights it. I think, taking out an IVUS probe when you have a bad renal function should be standard, because, you just have so much contrast on at the end of the procedure, and it makes it so much safer. I think it's important. Yeah. And our Asian colleagues know that very well. We don't have this, this philosophy, and it's really, it's great practice, at least in particular in Asia. When I travel to Asia, that's what I see.
Yeah, it's like going back to basic. It's not only the heart, we have to take care of the kidney also. So Sonia, please.
Oh, I just wanted to ask Dr. Ryan, and congratulate her on a great case. How does your team change when you know you're doing something complex, when you're doing something like minimal contrast PCI? Does your team sit down together beforehand? Do you add team members in? Are you always two consultants when you're doing a minimal contrast PCI? Can you tell me what's your practice?
No, so we work in the NHS, which is the National Health Service, and we're not perhaps the best.
I've worked in the NHS, I know exactly what you mean.
It's very rare that we have two consultants. Not to say I don't have fantastic colleagues, not to say that that they wouldn't come and help if you need help, but usually these cases are like this. I did on my own with a scrub nurse and a circulating nurse and our physiologist. We discuss the cases beforehand and we come up with the plan, and we say, we go through what we want on the table and open and ready and what's our backup plan. But no, I did my fellowship in Spain, and I'm very jealous of the fact that every complex case essentially has two consultant operators at least available, even if a fellow is doing the case. So
it's a very nice luxury, I think. Just so often it's not what's actually needed, but it's that safe space for discussion and anticipation. You can really have someone on lookout at the end of the bed looking for trouble. But it is definitely a luxury you don't always have.
So thank you. Sake of time, back to you, Sarah.
Thanks, fantastic case. So we're going to move along to our second last case, which will be presented by Dr. Karen Shek. She's from Hong Kong, China, where she's a second-year cardiac trainee. And she's going to tell us about some complex PCI, I'm assuming. Over to you.
Hello, everyone. Good afternoon. Today, I would like to share a case on left main shockwave that I did with Dr. Lam Ho a few months ago. So I would first like to share my screen. Okay, so a bit of background on this case. It is a middle-aged gentleman with a history of ischemic heart disease with PCI done in the private sector. We only know that the patient had his PCI to the RCA, but otherwise we did not know the exact details of the previous PCI that was done in 2012. And apart from that, he has metabolic syndrome, obesity, DM, etc. And he was presented to us firstly for exertional angina. And this time he was admitted as an elective case for PCI. So I'll play the video now. We can see that on the right-hand side is the coronaries. Left-hand side, it is the ECG and the hemodynamic status. We can see that before the contrast filling, that the vessels are very calcified. LAD is very diseased. The left main, there is about 30% stenosis. Diffuse disease over the LAD, heavily calcified vessel. Mid LAD was about 90% stenosis, distal LAD about 80% stenosis. The circ, osteocirc was about 50% stenosis, and on the right RCA, stent was patent, but the proximal RCA, there was about 50% stenosis, and RCA, there is distal RCA about 70% stenosis before the bifurcation. So we decided to discuss with patients whether he would like a high-risk PCI versus CABG. And the patient opts for high-risk PCI, so we proceeded with PCI. We plan to first deal with the LAD before the RCA. So we can see that we're using a run-through NS to wire the LAD. After wiring the LAD, we pre-dilated the vessel with 1.5 balloon and 2.5 balloon. There was a bit of difficulty in passing down another balloon to the distal LAD, so we used Guide Plus for assistance. After pre-dilating the whole vessel, the LAD, we decided to stent. Mid to distal LAD, we stented the vessel with the Coroflex 2.032 stent, and proximal to mid LAD, we stented with Coroflex 2.7538 stent. So after stenting the LAD, we can see that we're passing down the volcano IVUS to check the left main and the ostial LAD. On the left-hand side, we can see that it is a very calcified vessel. It is circumferential calcium over left main to proximal LAD, right before where we stented the LAD. So at that moment, I've discussed with my senior, and we have decided to first optimize the LAD stents before we proceed to shockwave over the left main to proximal LAD. So we have optimized the LAD stents with 2.0 and 2.75 NC balloons. And we then wired the circ for protection with a filter FC wire. I'll skip a bit. So this is where we optimize the LED stents. And we wired the circ. So we passed the shockwave. We use a 3.5 shockwave over the left main to proximal LAD. We can see that on the stent boost on the left-hand side that it is very severely calcified. So a total of 8 shocks was delivered. We can take a look at the left bottom graph. During the 8 shocks delivered, the patient was actually all along stable with no hemodynamic compromise. I think one of the very important reasons is that this is the patient has a very good LV systolic function. His echo showed a LV systolic function of about 60%. The valves are okay, and patient came in as a stable chronic ischemic heart disease with exertional angina instead of having a previous episode of acute coronary syndrome before the PCI. Another reason why we chose shockwave was because at the moment we would like to wire the circumflex to protect the circumflex. So yeah, that was the reason why we chose shockwave at that moment. I'll skip ahead. So during the last cycle of shock delivered, the balloon actually ruptured. But then, as we can see over here, that patient was completely fine. There was no arrhythmia. The BP was okay. And actually, in our center, it's quite a frequent thing that happened during shockwave. And our experience is that the ruptured balloon actually is okay for our patients. We haven't seen any complications that has arise from that so far. So we put in a stent, another CoreFlex stent, this time a 3.532 stent from the left main to proximal LAD, overlapping to the previous stent. So after deploying the stents, we can see that the angiographic result is satisfactory. And I put stent high pressure to the left main and proximal LAD stents with an NC 3.25 balloon and a 4.5 balloon at the very proximal stent edge. So this is the final IVUS right here. We can see that the stent's expansion and apposition is satisfactory, which is compatible with our angiographic results. And there's no complication seen over here. There's no dissection or any perforation, which we will do a final angiogram to make sure there's no acute complication and the coronary flows are good. So this is the final results for this PCI. Okay. So this is the end of my case sharing. Thank you very much.
Fantastic. Thanks so much for that really interesting case and exciting use of shockwave there, lithotripsy. I have to say we don't actually have lithotripsy in our centre yet, so it's always exciting to see it being used. I might hand over to some questions. We've got a few. Merida, you want to go first? You're just muted, just unmute.
So congratulations on the case. As I heard that you use a lot of lead strips. Do you have experience in patients with not such a good ventricular function and using the same device, the shockwave? Because from my experience, when you have to keep the balloon inflated for at least 30 seconds, it's when you get the patient to really feel it. So I would like to know if you have any hint of that.
As I've mentioned earlier, I think that the patient was stable during the 8 shocks delivered was mainly because of the very good LV systolic function. So even without the mechanical circulatory support, without any inotropes, the patient was stable and could tolerate the shock waves during the procedure. And of course, personally, I don't have much experience myself on patients with very poor LV function doing shockwave, but this is what I personally think might be the reason why this particular patient could tolerate these 8 cycles of shockwave.
Thanks, Karen. I mean, I have to say that was my first thought as well. How long can you inflate this shockwave balloon in the left main without complications? Helm HO, I'll hand over to you.
Okay. I want to share some tips and tricks and for the use of shockwave in left main. In general, it's safe. No worry. No worry. I know that they heard worry about occlusion and then we have some problem on hemodynamic, but most of time is okay. There are 2 main important things. One is the deliverability of the shockwave. It is very difficult to deliver even in left main, so you have to make sure you wire everything in good position and then you deliver the shockwave. And the second thing is you always have a wire in circumflex before you shock the left main. That is the painful experience we gain. If you don't have a wire on shirt, sometimes if you shock and then cause dissection, hematoma, and then it can cause the circumflex, and it could be very terrible. And that's my sharing.
Thank you. I'm not sure who was next. We'll go to Nicola first.
Yeah, I was just going to comment on shockwave in the left main. We've had shockwave since essentially it came out in Europe, and we use it regularly in the left main without any major problems. And as you previously said, obviously having a wire in your circumflex is very helpful, and it is one of the advantages as opposed to rotablating. And the one thing that's helpful is just giving a little break between the cycles of the shockwave. So you give your pulses, stop, give your next set of pulses, stop. But generally it's very well tolerated and it makes your procedure so much easier.
Fantastic. Livia, we'll go to you next.
A very exciting case. I really like that you, Karen, you did this so difficult case as a fellow, and they teach you very well to do the case. I was just wanted to highlight that you can use 2 wires, as you said. When you do rota, you can't use 2 wires, but with the balloon, you can use two wires, and it's not a problem doing shock balloon and with 2 wires.
I'm sorry.
It was not a question. It was that I just highlight
just a comment.
All right.
Just a comment.
I think that is obviously the teaching tip of the day. Use shockwave so you can wire your left circ. Sounds like a good plan. I think we'll go to Eric. You were next with your hand up.
I think we need to explain some caution about shockwave. We were all very excited about it. We thought it would be a new holy grail, but I don't think it's as effective as at the kidneys. I would say we had ruptures at 4 atmosphere. You have delivery issues. It's not, and you need often to combine it with rota first, and we are sometimes disappointed. You have 8 cycles. You have to decide where you're going to shock more, where you consider there's more calcium, and of course you can have nice images on IVUS or CT where you see the breakage of the calcium. but it's not always that holy grail. That's why I wanted to make, and you need to combine it with high pressure, potentially with OPN balloons, but it's not just a single standing technique. It needs to often to be combined. And importantly, size the balloon exactly, match it exactly to the size of the vessel. So that may be an issue in the LED. We have tapering from proximal to distal.
Good points. Mirvat, you had a few points.
Yeah, so for patients with impaired LV where I don't want to use ablative therapy and I want to keep the procedure as short as possible and as simple as possible, IVL does sound attractive. The thing is, there isn't a concern. So if you have circulatory support like this case, then you can inflate for as long as you want. But in any case, you're only going up to 4 to 6 bar, and most of the time it's not occlusive. And you can't take breaks in between. The only caveat is actually what Eric just mentioned, is that you really want to be appropriately sized for a vessel as big as the left main in order to achieve your results. So, you know, some people I know do try to undersize because they're worried about obstruction and to make sure there's still some flow around the balloon. But you run into doing a suboptimal atherectomy when you do that. So if you're going to do it, just do it right, size it properly, and be prepared that, yes, you may have a hematoma. These big balloons tend to have a hematoma, actually. And so just be cautious that that doesn't disintegrate into something worse than just a hematoma that you're going to eventually stent, meaning that it's section that can be flow limiting in a major vessel. But it has simplified the procedure a lot. So if you do it tactfully, I think it's a little easier than rotablation and so on. And in all cases, all ablative therapies are not standalone. So after rotablator, IVL, laser, what have you, we always balloon and try to make sure that, you know, we've achieved the size we want.
And Lemho, you had a comment further?
Oh, yes, I just want to emphasize Volta and Shorewave, they are not enemy, they are fans. You can do it together. Just like Eric mentioned, they are good fans, actually.
Absolutely. Fantastic case. And I'll hand back over to Merida to present our last, certainly not least case.
So I'm very happy to present our last presenter, Julia Steele from Switzerland. She's a senior physician in the University Hospital in Zurich and has many interests, among them valve interventions, coronary interventions, and microcirculation. So here to you, Julia.
Thank you very much for the introduction, and thank you very much for having me here. Very pleased to be part of that and share this last case with you. I'm just going to share my screen here. Very good. So starting with the first slide here. Great. So I'm sorry. Yeah, I'm talking about transcatheter edge-to-edge repair. I'm mainly not calling that MitraClip because nowadays we also have Pascal. So I think we should just use the term transcatheter edge-to-edge repairs for complex mitral regurgitation. My name is Julia Steele, and I was already introduced as a consultant interventional structural cardiology working in University Hospital in Zurich. The title of my presentation is Pathologies that Go Well Beyond Everest 2 Inclusion Criteria. And as you know, the ones of you who've been sticking around long enough to remember Everest, Everest had very sort of strict inclusion and exclusion criteria. And one of the inclusion criteria was that basically, as you can see here, the primary regurgitant had to be originating from in the middle, basically from A2, P2. And however, more than 1/3 of patients with primary MR have a non-central jets, and we need to address that. So our case is a 70-year-old male with ischemic cardiomyopathy with an LV ejection fraction of 45%. He was presenting with shortness of breath on exertion and decreasing exercise capacity, had a history of mechanical aortic valve replacement in 2006, and his comorbidities were coronary artery disease, had previous PCI of the LAD and circumflex artery and asthma. So in this guy, even though he had sort of only mildly reduced ejection fraction, was sort of hesitant to have this patient undergo surgery again. And when we saw this severe mitral regurgitation arising somewhere from the A2P2 region with a very eccentric jet, we thought, okay, we need to know a bit better what's going on here. So this guy underwent TOE, and in the TOE we actually saw here that he had a thickened A2 leaflet and slightly thickened as well P2 leaflet. You can already see here it's slightly prolapsing. Both of the leaflets, probably due to elongated chordae. As I already said, the LV function is only mildly decreased. Otherwise, I think we don't see any other abnormalities. You can also see here, for the ones who are not very familiar with TE imaging, so basically this is the LV outflow tract view, and if you take an X-plane to that one, here you see A2P2. If you take an X-plane to that view, you will go to the bicom view, it's called. So you see, you have here basically a view through the commissures of the mitral valve, with here P1, A2, and P3. And you can already see here again this prolapsing here of the P3. Now the thing is, with pathologies that are more towards the commissure, like we saw in this last view where you saw them mainly P3 was prolapsing, is that you need a bit different views than just the standard views. You see here, this is the color view of the normal LV outflow tract view, and here the mitral regurgitation doesn't look that severe. However, we knew from the TT that there was very severe mitral regurgitation. So you need to have a good echocardiographer who sort of can adjust these views to a bit special views to go more towards the commissures. And when you do that, then you suddenly see that there's a very broad jet with a big vena contracta. You see the same picture again. Now, what we always do, or what I always like to do, is take a 3D image of the valve. Basically, what we always do, especially when we plan for a TR, is we take a surgeon's view. Surgeon's view is, you call that surgeon's view because that's how the surgeon's gonna see this mitral valve. So here, this is the mitral valve looking from above. This is the aortic valve here, and hence this is basically the septal part of the mitral valve, and this is the lateral part. So this is the the anterior leaflet, and this is the posterior leaflet, P3, P2, and P1. P3, the one closest to the septum. And you can already see here, basically, that this part and this part are prolapsing slightly. So probably A3, P3, maybe a bit A2. You can see here very, very well already without color that these parts are all prolapsing. And what you can also see here is that basically you actually have a little coaptation defect, as you see here, where the mitral valve is not closing properly. Now to fix this, we have different devices, as I said in the beginning. Meanwhile, we have an alternative to MitraClip, which is the Pascal, but I know that plenty of you probably have more experience or have only access to MitraClip, and that's why I show a case where we actually used MitraClip. By now we have the G4 system, which gives us 4 different kind of clips. Basically, what you can remember is NTR and NTW, they're the short ones. W are thicker ones, and NTR are thinner ones. And then XTR and XTW are just longer than the NT one, but also here you have a thin one, the XTR, and you have a thicker one, the XTW. And you can see here in this picture. Very important also, what I really like with the new G4 is that you have continuous atrial pressure monitoring, which is particularly important for functional MR, but as well, obviously, for structural MR. Now, in this case, you'll see later on why we chose which clip, but we went for an NT ARC clip, and that for various reasons. First of all, when we do very commissural pathologies, we always have the problem or the fear of getting entangled into the chordae, and you know there is a lot of chordae in the commissures. So we try to basically take a very rather thin clip and a rather short clip. So we have a very little interaction with the chordae below the valve. Maybe you can think, or you see the result in the end, maybe we could have also gone for an NTW, as I told you, the thicker clip, and like that, get more of this jet basically reduced with one clip. So we are here at the start of the procedure, and you see this tenting here in this is a 4-chamber view, and you see this tenting in the septum, in the atrial septum. And for a very medial defect, as we do have it, we need a very high transeptal puncture. Otherwise, we can't sort of bend the clip, bend the delivery system enough to reach this very medial defect. And maybe important to know as well for you, when you see next time a procedure, the vena cava is actually perpendicular to the mitral valve. So if we want to be very superior above the mitral valve, that doesn't mean we need to be superior in the vena cava. It actually means we just have to be very posterior when we do the transeptal puncture. And the very posterior puncture will bring us superior above the mitral valve. And when we look here, we have like 1, 2, 3, 4, a bit more than 4 centimeters above the mitral valve, which should be enough. When we go down with the clip, we basically want to go just above the defect. And you see that's what we're trying to do here. Again, we have this LVOT outflow tract view here. And then with X-plane, we find the bicom view. And we try to get here really medial, where we know where this prolapse of the P3 leaflet is. And then once we're there and we know we have a good trajectory above the valve, we try to orientate this clip. And again, here you see the basically difficulties and problematics that you can have with this commissural pathologies is basically when you're here, you can't align the clip anymore like a straight line. You basically, because the mitral valve is like, I always imagine it to be, you know, a laughing face. It really has this shape of a mouth, of a smile. And when you have this medial pathology, you also need to turn the clip accordingly to be perpendicular to the valve and sort of grasp the leaflet and anteriorly and posteriorly at the same height. And you see here in the 3D view, we're definitely not very well aligned yet. Once you've done your alignment, then you cross the valve. And here again, because of this commissural pathology, you want to minimize any turning or any manipulation of the clip below the valve. So you want to check that when you cross through the valve, you really do that without turning of the clip. So you actually use fluoro as well, a tool that we interventional cardiologists are much more used to, and actually is really helpful as well with this procedure. You use fluoro while you cross through the valve, and you check that your clip exactly stays the way you aligned it before. Now you can see here, even though we were actually really nicely medial before, our clip is definitely not as medial anymore as we wanted it before, and sort of shifted a bit through into A2P2 region. We sort of managed to get it a bit more medial, and then basically made our first attempt of the clip closing. you see here, this slide is actually not the first attempt. This is like the 5th or 7th attempt that we did, because it was really hard to grasp these leaflets. Now, for those who have never seen that before, you can actually really, if you look at the right part of the picture, the alveolar tract view, you can actually really see how now you've seen the grippers dropping, and now the valve, the clip is closing. Now, basically, once you have your mitral clip well aligned, and you drop and you decide that enough leaflet is in, then you drop the grippers, and then you're fine. You don't have to. There's no need to rush, because normally the leaflets are very well attached by just the grippers, and you can actually. I'm just gonna pause this quickly. See now, basically, you see the grippers are down, and you can actually really look how much of the leaflets are below the grippers, and you actually see how the grippers are moving with the leaflets. You can see it's going up and down depending on how the leaflet is moving, and that gives you a lot of information. First, how much of the leaflet is in the grippers, and you want that to be at least 6 millimeters for the NT clip, or 9 millimeters for the longer clip. And you see if they're moving excessively or if they're moving normally. And once you have that, then you can close the clip slowly. Always remember there's a delicate valve attached to it. So close it slowly and move the delivery system slightly forward, so you're not applying any tension on the valve. Now, we first looked at the 3D view again, the same surgeon view that I showed you before, and this you actually do to see if you have a nice tissue bridge. And I don't know, but I feel like you see there's a nice tissue bridge, but you can already see that it's sort of, it doesn't look, it looks slightly sort of turned counterclockwise, a bit more than we maybe want to. And what you see here on the right side is that basically we actually still have a big collar jet coming off the more medial of the clip. Here's the clip, more medial of the clip and more lateral of the clip. And I think if you see sort of a very big jet arising from a spot where before there was no big jet, I mean, before our jet was mainly here laterally, then that sort of has to ring your alarm bells, you know, because a new jet during a TR procedure always means that you've basically probably pulled some tissue somewhere, distorted the valve, and basically made it worse than it was before. So always remember that if there's a new jet arising, or suddenly there's an eccentric jet where there's been no eccentric jet before, better to really open the clip again and start from scratch. Now, unfortunately, that wasn't done here, so we left the clip like that, and as you can see, once we let it go, we really had this very big jet now coming from here, more medial from the previous one, and sorry, more lateral from the clip, and also a little jet more medial. Hence, we had no other option than to add another clip. And now you can already see where the problem is. When you have a very commissural defect, you need to put this clip as much to the side as it possibly can, because otherwise you will never be able anymore to fix this more medial defect that we have here now. I mean, you will not be able to put a clip basically medial to this one. It's just too small. Now this is our second clip. Again, for here, as we can use fluoro very well to basically align the second clip with the first clip. You want to have it not necessarily exactly the same orientation, because as you know, as I told you, the mitral valve has this smiley face. So probably it is a bit, it is not exactly parallel to the first one, but you can definitely check, are you pushing on the first clip? You don't want to detach it, and are you very close to it, and that's what you want. This is the picture now after closing of the second clip, and you see we still have more MR than we actually want, and it's still a bit eccentric, but we sort of had to live with this result, even though it was not very satisfying. Now, in the outpatient visit after 3 months, patient definitely had increased exercise capacity, even though he had residual moderate MR, and he had a mean gradient of 2 millimeters mercury. Take-home message, I think we can say percutaneous repair of commissural pathologies is challenging, but possible. Careful device alignment and manipulation are important. Try to do as little manipulation below the valve in the ventricle. Try to really align and just the clip above the valve. Optimize transeptal puncture is key. So go very posterior and try to be superior above the valve. And you need to have a really good imager on your side, because imaging is challenges. You need unconventional views to visualize clip arms and valve tissue during grasping in this commissural defect. Now, specific to our case, I think we should have aligned the clip better in the beginning. We should have put our clip a bit more medial, as medial as possible, basically. And I didn't tell you that when I was talking about the new 4G system and the Pascal device. What you can do basically with these new iterations of the device is that you can only, when you want to optimize your leaflet grasping, you can actually just lift one gripper and then move with the system a bit closer to the leaflet that you want to grasp again, and then drop this gripper again and close the clip. And basically what we think is that you should try to do that in every case. Even if you think it looks okay, it is likely that you can make it even better. Now, having said that, I think there are still true contraindications for clipping if you have a very short posterior leaflet, if there are clefts in the grasping zone, not necessarily clasps, but you can work with clasps, but not if the clasp is in the grasping zone. If there's calcium in the grasping zone, if you have a very high transmitral gradient or a very small mitral valve orifice area of less than 3.5 square centimeters. If there are leaflet perforations, obviously you're not going to be able to fix that with a clip. And here I said commissural lesions, but obviously if it's really in the commissure, then you can't fix it. But if it's just very close, then that should not be a problem. Good. Here I'm at the end of my talk and happy to answer any questions.
Thank you, Julia. It was a really good case. I like it. It's not easy to perform meter clip. And I think there are many of us who are not very expert in this field. So I like the first question from Jack.
Yeah, thanks, Julia. I like the way you narrated the case. I'm just speaking from the Asian experience. I think in Asia, the hearts are rather small. So I think you narrated the difficulty of this case where it's pretty medial. The leaflet, especially posterior, is very short. And therefore, in Asia, a lot of times, even though we try to aim posterior and high, we still have to do extra maneuver to get it higher before coming down medial. And I agree, you would have needed to come a lot more medial in your biplane view to bring it closer to the commissure. I think your choice of NT or even NTW, like you said, would be a good choice. I think this would be a two-clip case. It's just that particularly in Asia, a lot of times we are limited by the gradient because the valve itself may not be that much bigger. But I think the emphasis is to try to get the MR at least a 2-grade reduction, which is what you achieve. And of course, you didn't show us a pulmonary vein waveform and the pressure reduction for the V wave, but I'm sure you had a very good hemodynamic result as well. Eric probably has more experience than me. Eric?
Yeah, I think I think what was very nice, the way you explained to the audience who has maybe less experience in MitraClip, how to proceed in every step. So I think that was important, very didactical. Indeed, the puncture rate is quite high. I didn't see how posterior you were, but indeed, I think there are some points to mention. Ventilation that has to go down, tidal volume, tips and tricks. I think the issue was the short posterior leaflet, and probably you were a bit too much at 10 o'clock. If you would have been more at 11 and a bit more medial, but of course, the more close you get to the septum, the more difficult it is. And also to mention for the attendees that putting in the second clip is quite tricky because you have to, on 3D, decide at which position you will put your second clip. Is it at noon? Is it at 1 o'clock, at 12, 11 o'clock? And then once you have decided, you have to close your clip. You cannot cross with an open clip. And then you have to hope that once you get below the valve, your clip doesn't turn, because then you may try to turn the clip below the valve, but that's tricky because of course there is the apparatus, but sometimes you don't have any other choice. So it's more tricky than what people can imagine, but it's a great technology. But this is indeed not an easy case. And as Jack mentioned, in particular, the short posterior leaflet is an issue here.
Thank you, Eric. Mirvat?
I just want to follow up on what Jack was saying. I did notice it in the Middle Eastern or Gulf population as well, and it's interesting to hear that you see it in your Asian population as well. Our patients are petite and their left atria are not huge, and so achieving height in a lot of these can be challenging. And some of them, when the left atrium is still dilated, it actually doesn't dilate in length or height-wise, it actually just balloons outwards a little bit. So we find ourselves sometimes scraping almost just below the roof of the atrium and then trying to manipulate in order to achieve, flex the device onto the valve. And I think maybe this is an excellent platform for us to consider maybe a registry across the Asia-Pacific region and just kind of look at, what are our population demographics looking like for these patients? How many of them actually do have short? Is it just an impression that we have because we're remembering the patients with short atria or, where we have difficulty with height? Or is it something real? So I really think we should look into it and collaborate to kind of come up with something.
Yeah, that's a good point. Leticia, please.
Yes, I will make a question because I don't know, I have no experience in this technique, but I mean, I want to know if Pascal platform may offer an advantage in this case, or what kind of the anatomy or procedure may be beneficial, the use of the Pascal platform. I don't know, is this
I can answer this question.
Yeah, Eric, go ahead.
It's delicate. I must be careful what I say here if the industry is watching. Well, I think Pascal may be easier once you get entangled in the chord. Pascal may be potentially easier to pull out because it's like a frog, I compare it to a frog. I'm not sure because I have not encountered the situation yet, but I think both techniques are there and they're good technology. Pascal was basically the initial company who had this asymmetric lifting of the grippers. They were the first to develop it, and then basically Abbott corrected and now made the device that also can be selectively lifted up. So it's competition increases quality of the devices. So I think that's the most important message. I think what I would say also, Jack and our colleagues, our issue is sometimes the fossa, it is quite small. And I think, Julia, you will agree, in our European patients, you may have a very small fossa. You try to go high, but you're not supposed to puncture into the muscular part, upper
exactly.
part.
And
so that's a trick.
They're very, thank you for this comment, Eric, because that was actually just what we did in this patient. We actually went through the muscular part because there's no way, we were just like, every time we punctured, we were just not high enough. So at the end, we went through this muscular part, but I've seen once actually pericardial effusion complication. And, you know, it only happens once you pull out this the guides that basically this is from, you know, the ones who can still remember embryology from our medical school. That's basically there where this, so this the septum involutes, and that's why you can get pericardial effusion when you puncture the septum there. But sometimes it's just, yeah, it's not like in this case, it wasn't possible to go otherwise.
Maybe a final comment about the Pascal and mitral clip piece. I think the pitch for selective gripper selection, I'm not too sure about Julia's comment, because I'm quite wary about selective gripping and trying to swing the clip over to grip the other side, especially for valve, I think, and tear. And I do it selectively just to check rather than routinely. Yeah, Julia, sorry.
Just want to make that clear. I absolutely agree with you. I wouldn't do selective gripping. I never do that. I think it's too much force on the valve. And but what I was talking about is basically optimizing. You know, once you sort of have both grippers down or clasps, if you use a Pascal, and then basically you close it and you see how it looks, and then just optimize it. So just basically swing it tiny bit left or tiny bit right, you know, but basically not the independent gripping. Sorry, I wasn't. I hope I am sorry. Just to make that clear, I also think the independent gripping there's just too much force on the leaflets.
You can do it basically in this case if you because the difficulty is to get the posterior one. So go very posterior, grip both, then unlock the anterior, and then you can really turn anterior and try to get more anterior. That's something you can do, Jack. That's something that's safe. We did that quite often.
Yeah.
Sorry for the other attendees, because that sounds a little bit, but that's. I can only tell you, you know, it takes so much time to understand mitral clip and you know, edge to edge techniques. It's a really year-long learning experience. And imaging also, I think the role of imaging. And if you don't have a good echo, guys, just then just forget. Don't start in mitral intervention program.
Yeah.
Thank you very
Totally
much
agree
for
with
that. That comment. I think that in the sake of time, we have to begin to close this. So I would like to make a brief comment on three of the cases. The first one, it was the case where Livia presented us this rupture of the aorta. And I said that we learned first to be prepared, second to keep an eye of our wires, and then third to always keep good communication and if possible teamwork with the vascular surgeons. Another good comment is for the Nicola case. It was a very good case. I think we learned to approach patients in a global way also, because they took good care of the bleeding point and also the kidney function, and was very nicely and elegantly done. And I think we also learned that. And for the mitral clip or the valve repair, I think it's a field where many of us are not quite familiar yet, but as Eric just mentioned, it's a complex, and as Julia put the case, it was not as easy as it seems in the first program images that we had. And I think that's the most important issues I can online for these three cases. Back to you, Sarah.
Fantastic. I just wanted to really quickly wrap up, given that we've gone over time, but it was such a fantastic case sharing. So I wanted to say thank you to the Transcontinental CHIP Case Sharing Club, particularly Dr. Lam Ho, who really facilitated this incredible event. And thank you to all our wonderful speakers and panelists joining us from all around the world. And I really think we've showcased such an amazing group of cases, and all presented by outstanding female interventional cardiologists. So thank you everyone for attending.
And thank you, Lam, for preparing all this. Thank you all.
Thank you, everyone.
Thank
Bye-bye.
you. Bye.
Thank you. Thank you.
Thank you.
Bye.
Bye. Bye.